Hi, Philadelphia. I'm Dr. Rachel Tate from West Palm Beach, Florida, and I have an honor today of introducing you, if you don't already know her, to my friend Dr. Alexis Ogdie. Alexis, thank you so much for being here.
Thanks so much for having me.
You are prolific with everything that you do, but one of the abstracts that really spoke to me this year is Abstract 1600. Can you tell us a little bit about it?
Sure. So this is a study from the CorEvitas Registry among patients with psoriatic arthritis who had failed their first TNF inhibitor and then were switching to a new TNF or switching to a new mechanism of action. So we examined the outcomes over the next 6 months and then the next 2 years, and we found that patients who switched to an alternative MOA actually did slightly better. It wasn't a lot different, but it was a little bit different than someone who switched to another TNF inhibitor.
So I think this is really interesting because we talk about this all the time, right? And unfortunately, a lot of our decisions tend to be made based on what we can get access to for our patients. But when it comes down to it, how are you treating patients in clinic in an ideal world?
Yeah, so in an ideal world, I usually will, if they did really well in that first TNF inhibitor and they were on it for a long period of time, then I'm going to go to second TNF inhibitor usually. But if they didn't do so well or they kind of had a stuttering course, then I might switch to a different mechanism of action. So there's some nuance, so you can't put into a study like a registry study.
Well, absolutely. I mean, and I think there's a big difference between loss of efficacy and lack of efficacy, which is really kind of what you're highlighting.
Exactly.
So when it comes down to it, how long do you tend to wait for these patients to have a response? Again, nuanced, I know.
Right. In general, I tell patients I'd like them to try it for 6 months, because if we're switching before 6 months, there are some people who will continue to respond out to that time. So
I really appreciate the way that you treat patients, because I think it's very common in what we do in general for patient treatment. But one other thing that you mentioned today is that there's another abstract, which is also quite interesting. It's abstract 402 regarding opiate use. Can you tell us a little bit about that?
Yeah, so one of the things we're also interested in is how do we get patients feeling better overall? And we know that a lot of patients aren't feeling well, and there's actually still a lot of patients utilizing opiates, which we know to be bad for many reasons. So in the Forward Registry, which is a national database for rheumatic diseases, we examined patients with psoriatic arthritis and axSpA, and we looked at the prevalence of opiate use and then how those patients were different and were they being treated differently. And so you might think maybe they're not getting enough of the DMARDs or biologics, for example, but actually they were getting more. And so they tended to be people who were just not doing as well. They had higher healthcare utilization, higher patient-reported disease activity. So these patients, you can tell, are just not doing well. So we need alternative approaches to getting patients to that lower level of disease activity, or the perceived disease activity, and better quality of life.
So I think perception's a really big deal for our patients. I mean, if they respond and if they feel they're responding, ultimately their own pros, right, patient-reported outcomes tend to be a little bit higher. That's data we're all familiar with, but are we actually capturing it? And I think that's a really clinically useful discussion, and it changes. It's nuanced, as you said. I mean,
exactly.
So is psoriatic arthritis and psoriatic disease. So.
Yeah, and it is tricky, and I think sometimes people are maybe quick to reach for the opiates because it's easy. And I think this is the point where we need to slow down and say, all right, what else do we have in our toolbox? Because there's many other things that we're not maybe utilizing as much as we could.
That was beautifully stated. There's no other way to really have that discussion without having that discussion. And you are my dear friend, and I think you have such an amazing plethora, the way that your mind thinks epidemiologically, et cetera. You've gifted that to the ACR, amongst other publications. But what I really think is interesting is the way that you have utilized your background to create this amazing career for yourself. And you have also been involved with FIT, right, the fellows. And so if you had one piece of advice for our fellows in training, what do you think that would be?
Persistence. So stick with it. Find something you're passionate about, and then don't get off that track. Just stay on the track.
You, my dear, are one of the most passionate people I've ever met.
Thank you very much.
Thank you so much, Alexis. Thank you for giving of your time, your energy, your effort. And as always, follow us on rheumnow.com, but also follow me on Twitter at UpToTate and Dr. Ogdie at
Alexis Ogdie. I can never remember my Twitter handle. I'm on LinkedIn for sure. And maybe it's Alexis O. Thank you.
Yes, absolutely. Well, don't worry. Find us on Twitter. We're here for you. And thank you again.
Thank you so much.